the time.
Okay, and I touched on this briefly, but I want to go a little bit more into it because I want to make sure I understand that you were not involved at all in the patient selection or screening.
No.
Okay. Were you ever consulted by I think you said Dr. Chi and Dr. Nazari were involved in that process?
Yes.
Okay. Were you ever consulted by them as to who was being selected to be part of this study?
No.
Did you ever discuss with them how they went about
No.
choosing who was going to be
No,
part
because
of
we had criteria.
Okay.
It was very specific, and of course, I expected everything was going to be followed like that.
Okay. So you expected that they would follow the criteria in selecting those patients?
Correct.
Okay. And you mentioned earlier that it is preferred within the protocol that one investigator handle the procedures from start to finish. Is that right?
Always.
Okay. And when you say always, I want to know if that is standard practice when a clinical trial is being conducted.
Objection, no foundation.
You can answer.
This is accepted to eliminate the variables of error. Okay, to have a constant error, or okay, when you have a constant error, it's not no error.
Okay.
Because it's the same operator. It is, for example, in my study. Okay, I did all 52 surgeries, all of them. I reopened all 52 patients, surgically, and then I got up and somebody came in to do the measurements.
Okay.
It's called blind evaluator, who knew nothing about,
how you actually operated and opened it up.
Right.
But his sole job for all 52 cases
measurements.
was only to measure.
Right.
And are you saying that that is...
Just a scientific method.
Okay.
Sorry, say again.
Scientific method.
Okay, and this is through all of your years of experience how you try to limit the amount of variables that can occur
Right.
in that regard.
I think in this study we're talking about, this was done, I think if Nazari put all the implants.
Okay.
I think that was done.
Okay.
However, from a restorative standpoint, I don't know. I wasn't there, or I don't know. My feeling, graduate students were involved too.
Okay.
So,
but you're guessing about that,
I'm
and
guessing.
I don't really want you to guess.
No, I might, exactly.
What I do want you to tell me, though, is from your experience, whether having someone else perform the restorative function would have an effect on the results.
Objection calls for speculation.
The restoration is the most important part of the implant.
Okay, that's what I want to focus on, and I want to
Yes.
know
If-
exactly why you're saying that the restoration aspect of an implant is the most
because
important.
it is, if the restoration is faulty, the whole thing will collapse.
Meaning the implant beneath,
Will collapse. Will go. Yes.
and why do you say that?
Well, because the final restoration has to have the proper contour, shape of the teeth, same size of natural dentition. If it is too bulky, okay, food hide underneath it. If it has open margins, things could hide underneath it. If it is too much bite, it will kill the implant. If it's not enough bite, it will lose, this is all data available.
Okay. You just have to remember, I'm not a dentist, and possibly the people who see your testimony,
Right.
they won't be dentists, so you have to explain it to me and to
Okay.
everybody else in a way that we'll understand. So the fact that a different person may have been doing the final restoration of the implants would have a significant effect on not only the study, but on the success or failure rate of the implant itself.
Right. Scientifically, if you take this study to a bunch of researchers, okay, and say one person did this surgery, they love it. and you say one person did all the provisionals, they love it. You say one person did all the final restoration, they love it, and say this is valid scientific study, same carry through. But if you say one person did the surgery, great, but then say 20 different people did the provisionals, and I don't know, I'm talking theoretical now. Okay?
I understand.
So of course, scientifically, you'll be shot down. They'll say this is not a good study.
Okay, and we're talking purely from a scientific...
This is probably from my own opinion.
Okay.
This is my opinion.
And from a scientific standpoint, as opposed to what actually happened.
Right.
And I think what you testified is you cannot tell from either of the reports that you looked at today, Exhibit 3 or 4, whether one person or 5 people performed the restorative work on these implants.
Right.
Okay, and
especially if the person did the provisional, okay, in that case, I expect the same person to do the final.
But you don't know.
We don't know. That's what I'm telling her.
Okay.
I'm saying theoretical.
Right.
Okay? And this is basically basic knowledge. No.
Okay, and that
if you want to do research, you have to do it right.
Right.
Okay.
Okay. And your opinion is that this was not done right.
No, I didn't say that. I'm talking theoretical.
Theoretical, okay. And the type of information that you're asking me or telling me about, however, you can say that that was not included in either of the reports that you saw.
Exactly.
Okay.
And maybe the data answering my question is there, but it's not in these 2 pages you showed me.
Okay.
Did you understand my point?
Yes, I do.
Yeah.
I do.
I mean, if we go back to the school and get the patient record, you may say that John Smith did the provisional and John Smith did the final. Then I'm happy. You know, but I cannot answer that.
Okay.
From
Not
these
with the
reports,
information that
no.
you have, okay, in front of you today. Do you think that the data would be affected in this case if the operator, meaning the person who is doing any of the work with respect to the Sargon implant, was not trained in the Sargon system?
Objection calls for speculation. Incomplete hypothetical.
Do you understand what I asked you?
Yes.
Okay.
The answer, yes.
Okay. So that, I guess what your testimony was is you would be able to tell, maybe looking at the patient records, whether that person had training. Is that something that would be included in the patient records or not?
Calls for speculation.
I'm asking whether he knows.
That should be in the record, but that's not my point about the record. Is doing the provisional versus the final.
Okay.
Yeah.
Okay. And does the Sargon implant training include training from start to finish, including the final?
Yes.
Okay. And so that, again, this is something that you would be able to assess by looking at some record or not?
Objection.
Would you be able to tell that?
Objection vague. That's what the record says.
Let me ask you this way.
Yeah, I'm lost.
Okay, no, let me ask you this way. Is the fact that someone has had training in that specific methodology, the Sargon implant system, something that you, as a practitioner, would record on a patient record?
No, you're probably not. But you need the training to do a good job.
Okay.
I mean, that's
so those are 2 different things. So I'll talk to you about what you've testified to. In this particular instance,
right,
are you saying that it is imperative that whoever is doing the work, in connection with the Sargon implant system, has training in the Sargon?
The restoration, you mean?
Well, the restoration or any other part of the system.
Yes, absolutely.
Start to finish.
Absolutely.
Okay. And you had that training?
I had the surgical phase of it.
Okay. You did not go further to
the restoration? No.
Restoration.
Somebody else did.
Okay. And I think you testified earlier that...
The same thing in the study. Nozari placed them. Chi restores them, or supposed to restore them.
Okay. And so far as you know, there would be then no reason for Chi to really have training in the surgeries, because he was doing the restoration.
Exactly.
Okay, so he mastered the restoration part.
This is accepted.
Okay. Okay. Um, I'm not sure if I asked you this, and forgive me if I did. You said there was a time that the Sargon system was being taught at the school or not?
You know.
Do you know?
Yes, during that, based on these letters
Okay.
in the graduate program.
Okay. In the graduate program. Do you know how long that continued?
Oh, I cannot.
Okay.
I really cannot.
Okay, that's fine. In your private practice, how long, average time did it take to provisionalize the implant?
3 weeks, 4 weeks, fourth week, final.
Final restoration, 4 weeks.
That's the protocol.
Okay.
Because the protocol, the Sargon protocol, is very specific. You're going to know immediately it works or it doesn't. First week, no pain. Second week, no pain. Third week, no pain. Fourth week, final. If you have pain, you tighten it, and then you go final.
Okay.
So there's the guidelines.
That's
Good.
it. Simple as that. If you have pain, tighten it. What does the pain indicate?
Indicate looseness, that there's
Not-
some inflammation deep inside, yeah.
Not
Or the
attached to
bite, or something like that.
Something like that.
There's a protocol, yeah.
Okay.
And that's what we did. We finalized them quickly.
And again, that was for the reasons that
Overseas.
you stated.
Yeah.
So that the bacteria doesn't get caught under the provisional and that there's no problems later on with that. And you said that the Sargon system was very specific about that.
And function and everything else, yeah.
What are you specifically referring to?
This is standard about all implantology procedure. The provisional has to be good.
Okay.
You know, and if the provisional is not good, you know, then you have this, and the provisional is too long, then that's what happens.
But not all implant systems say that the provisional, the final, should be done in such a short period of time.
No, correct.
Okay, so the Sargon system is quicker in that regard.
Correct.
Okay. Do you have, well, did you hear in this case that the researchers or the investigators were deviating from the protocol with regard to final restoration?
Objection vague.
I cannot answer that.
And you can't answer it because you don't know, or
I do
because
not
you
know.
do not know?
No.
Okay. And by looking at the reports, were you able to tell how many of the patients within the study were given final restorations?
It says there, but doesn't say when.
Okay. And so that would be an important factor to you in terms of seeing whether the researchers had complied with the protocol that was indicated.
Objection vague.
Yes, especially if the report says there's a fistula developed.
Okay.
If the report says a fistula developed and the temporary has been on for 2 months or 3 months, then I'll say this fistula developed because you've been waiting too long to do the final. I'm just telling you from, as a clinician, when I read this, that's what I gather.
Okay.
That's,
And again, you never saw those, so you would not have.
no.
Okay. Does every study that you've been involved with have a specific protocol that needs to be followed?
Absolutely.
Okay, that's just a standard thing. Remember, I don't do this, so I want to know if
You
this
will
is,
never be funded for any research unless you have a protocol. It's like the plan.
okay. So that's at the heart of any study. Have you ever written or proposed a protocol yourself for a study?
Yeah, I have published many articles.
Those
Different
are two
question.
different things?
No.
No? It's not two
It's-
different things? I wanted to know whether, you said in this case that Winston Chee was the one who did the proposal, which
Right.
eventually became the protocol.
Right.
Okay. And I wanted to know if you personally had done that
In
other-
this study here?
No, for other studies, any study.
Oh, yes.
It's like a business plan.
Yeah,
For
the Atrix,
normal-
the study we've done, yeah.
You did that.
Yeah, all my graduates, 30 years, I have trained 150 specialists.
In endodontics?
150 root canals and endodontics, and every one of them had a research requirement to
Okay.
graduate. And they have to have a study plan.
Oh, okay, so that's what you call it as part of the curriculum?
No, the research.
The research?
Yeah.
Okay, and that means exactly what?
It means you have to investigate a problem,
Okay,
okay? Does this implant work or not?
okay.
Then we have to pick up some patients. These patients have to be this age,
Okay.
this sex, this race, for example.
Okay,
They all have to be healthy, and if they are sick, we don't include them. They're called exclusion criteria.
okay,
They have to be healthy. For example, they don't have immune deficiency syndrome. They don't have diabetes. They don't smoke. They don't take drugs. They don't take steroids. Anybody who does, they don't put them in the study. Okay, that is called sample selection. Then you have to have enough patients, minimum this number. You know, it's outlined in the scientific inquiry. You have to have sample, well-described sample. You include some people, you exclude some people. Everybody included, you bring them in. And then you have a methodology. We're going to do this, and this. Before the study, we collect this information, that information. During the study, you collect that. After the study, you collect that. You have data. Then the data has to be subjected to a statistical analysis. That's,
Okay.
Yeah, pretty much it's here, actually.
right. In connection with the Sargon implant, the protocol set out specific exclusion criteria. You're aware of
And
that?
guidelines.
And guidelines.
Right.
And you're aware of that criteria.
Correct.
And you're aware that, perhaps, for instance, a smoker would be excluded, correct?
Correct.
Okay. And do you recall any of the other exclusion criteria in this particular case?
Yeah, diabetes, chronic disease, immune deficiencies, they're all here. It's
Okay.
In B, appendix B.
Okay. Were you aware of how that exclusion criteria came to be? Or you didn't have anything to do with it?
From the literature,
Okay, what literature are you referring to?
the dental literature.
With regard to implants generally?
Yes.
Okay. And what I'm trying to find out from you is why would a diabetic not be a good candidate to receive an implant?
A diabetic have compromised bone repair potentials. They have a great tendency for infection. Okay, depends on the sugar status, and
It depends on
their sugar status, diabetes sugar, whether it is controlled or not. So they become very susceptible to infection, and that's part of the reason that's it.
Not a good candidate.
Bleeding and all of that problem.
So by virtue,
Gingivitis.
right.
They have very poor compromised peripheral circulation. Yeah.
So by virtue, just the nature of that particular disease,
Right.
not a good candidate.
No.
And why is a smoker counterindicated? Or I guess I don't know if that's the right word. but
Contraindicated.
Yeah.
contraindicated.
Again, you know, the smoking creates inflammation. Nicotine burns. Nicotine stomatitis, inflammation of the mucosa of the mouth. Again, it predisposes infection, makes it easier for the tissue to be inflamed and infected. You know, it compromises healing potentials, smoking, repair potentials. So again, from a standpoint of research, you eliminate these patients, you know, to control that variable.
Okay, and would you say that smokers, diabetics, and those with insufficient bone mass is just common knowledge that those are
Right.
not good candidates
Right.
for
For-
implants?
right.
Okay. And that's something that you knew.
That's what I told you about the bone healing problem.
I don't recall if I heard you say that. You mean, the bone healing?
Yeah, bone density in the
Yes.
beginning,
Yes.
and then once the bone is injured, it will not heal sufficiently.
I mean, if there's been a previous trauma to a particular area of the bone in the mouth, you're saying that that's not
the
going to...
surgery itself is a trauma.
Okay.
So we won't have sufficient healing.
Yeah, okay. So
Basically.
you... And how do you prevent against something like that? I mean,
You just don't include them in your study.
But you know that from looking at an X-ray or from some other...
No, the history of the patient. You take a medical history.
Okay, that's what I wanted to
And the
find
medical
out.
history will say, I'm a smoker. Do you smoke? You answer yes, no. I'm a diabetic, no, yes, no, and all of that.
Do you know whether any smokers were included in this particular study?
I don't know.
Okay, how about any diabetics?
I do not know.
Did you have, or do you know, by sitting here today, whether all of the patients included in the study had sufficient bone density to survive an implant
Very good.
placement?
Okay. Again, here is exactly what I'm telling you. When I look at this data
Yes.
from here, I cannot make these judgments at all because there's no history. A patient, it says patient 1, female, age 67, okay?
Yes.
That's only one variable out of 6 or 7 needed. I need to know more.
Do you know...
I cannot answer the question.
Do you know whether there was a upper limit of age exclusion in this particular case?
The study said they go up to 67.
No, the study, this report says that patient 1 was a female and she was 67 at the time of placement. Do you know what the age range was for this?
Up to 65.
Okay.
Patient number and age range. Age 65 was the upper limit, and 17 for girls and 19 for boys.
Okay. And then, so did you, you said, did you witness the first 20?
First 10, 20 implants.
Okay.
See, we go by implants.
20.
Some patients have 2 implants.
Yeah, oh yeah, I understand that. But assuming that patient 1, the female, had a 13 millimeter implant placed in healed site number 12, you probably were there for her.
Wait,
you don't know.
Wait a minute.
Yeah.
This is another point. We don't know whether patient 1 was the very first patient we did.
Okay.
This patient 1.
Okay. So you're not able to even tell from here whether you saw this particular patient. Okay.
This is not sequenced. There's no dates. So if there's dates, you'll know.
Okay. Okay. So you weren't able to tell when that person was prepped. I think you talked about before, and you came in.
No, they were all
to
covered.
watch the surgery. You couldn't tell if she was 65 or 25.
I didn't see nothing but the lips. Because they cover everything.
Okay. So there was no way you could have said, that this person does not fit within the criteria. They're older, younger, they're diabetic. They're
Exactly.
okay.